Hello and welcome. Moss Adams is pleased that you've joined us for today's session, Telehealth Considerations for Tribes. Before I begin, I'm going to play our housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and now I would like to introduce today's presenters from Moss Adams. We have Lori Laubach, partner, and Kim Hodson, senior manager. Their bios and contact information are located in your console for your convenience. And now I'd like to turn it over to Lori to get the presentation started.
Thank you, Amy, for the introduction. Sorry. My screen. Hi. So today thank you for joining us to discuss telehealth and how to identify some areas of risk related to telehealth. The PHE is ending May 11th, which is just in a few days, and there are various things that are changing, and we're going to talk about those items as well. But instead of purely focusing on coding elements of telehealth, we want to discuss how telehealth can potentially help the tribal communities. In addition, telehealth has been a front seat as to the concerns by regulatory agencies. As of this last week, there was a recent information sent out by the Office Inspector General about how to data analyze your telehealth services to look for risk and outliers. You know, with the PHE, we've seen public health emergency, we've seen volume increase substantially. The way care is being provided has also substantially changed. And so it's important that we think about what is in the government's raised as concerns about documentation, medical necessity, coding, and billing. And as you know, during this public health emergency, we've seen a lot of things change over the period of time. And so making sure that we keep track of that and we're billing things appropriately. I'm Lori Laubach. I'm a partner with Moss Adams, and I'm responsible for the regulatory compliance and healthcare internal audit practice. And I've been working with clients related to compliance for over 20 years. But I'm not a certified coder, and that's why I have great people with me that work with me as well. And that joining me today is Kim Hodson. She's a senior manager, and it's been wonderful to have her on our team. And she helps with regulatory compliance plans, programs, investigations, auditing, and setting up and monitoring processes to mitigate risk. So today our goal is to share updates and changes, and then kind of talk about some risk areas that we think are of concern. So we thought we'd start here with a question. So we'll go ahead into our first polling question. So our first polling question is, what type of entity is your organization? So are you a tribal health facility with medical, dental, and mental health? A tribal health facility, only medical, tribal hospital, not a tribal health facility, and none apply. It's interesting, I was reading a US News article that cited an entity called Fair Health, F-A-I-R in capital letters, that tracks telehealth trends on a monthly basis since January 2020. Throughout 2021 and in January 2022, mental health conditions constitute the top telehealth diagnostic category that was being documented, in particularly with telehealth services. So it's kind of interesting to think about that. So how much that that was focused in on mental health, but it was a diagnosis somewhere in that patient's chart that demonstrated that. It was on a claim. So how are we doing? Looks like we have a large percentage of the folks that are none of apply of the items that we've listed, but and not a tribal health facility. So Kim, do you want to do the next polling question?
Yeah, absolutely. So how are services currently provided in your organization? Are you all in person? Are you completely telehealth? Is there a hybrid between in-person and telehealth? Greater than 50% or less than 50%, or none apply? And I'm curious as to our last polling question, what type of organizations we have on the phone. If you wouldn't mind adding that to the chat, I'd love to see where everybody's from. One of the statistics that you were mentioning, Lori, kind of reminded me of another statistic that I heard put out from the National Center of Health Statistics just fairly recently, October-ish, and they were saying that 37% of adults used telemedicine in some form of capacity in 2021. It's a huge percentage, and that percentage is increased in the tribal health arena.
Yeah, and just thinking my husband actually is using telehealth. I never thought that would happen, so.
Okay. And so it looks like here we have majority of none apply. Oh, we have some, let's see, a tribal broadband provider. Thank you. In our group today.
Great.
Okay.
So let's get going on telehealth today. Before I get going on this as well, I wanted to share an article that I had read in the New England Journal of Medicine, where the author provided some key questions to think about, especially kind of pushing it toward Congress and regulators about how to extend, expand, or curtail telemedicine. And the first thing it's saying, asked is, does it save money or does it spend more? It was expanded, for reimbursement for certain populations, such as rural areas and certain types of care, such as acute stroke, but they're relying on the assumption that telemedicine is actually cost effective. And so the question is it really, what balance do you need to have in order to make it cost effective? Is it safe to treat patients remotely? That's the other question. There's been a variety of trials out there that have actually looked to see if in-person care is different or safer than if it's on the telemedicine. And it's interesting when you look at those studies, they're not a large sampling of entities out there, and it doesn't cross like it's all telehealth type provider or it's all clinics, or it's a hybrid, but the hybrid mix is not the same across all of them. And the last one is, really, does it provide health equity? Telemedicine the hope was that it would advance health equity, but make the members of underserved population obtain care and narrow that disparities in access and outcomes. But because of this digital divide, which we're going to talk a little bit about in a few minutes, is some of these are underserved populations may be less likely to use telehealth just because of having access to this type of systems that they can use in data. Okay. So one of the things I like to do is when we're doing a presentation about telehealth is kind of level set. And I think this is straightforward for everybody, but HRSA, they actually define telehealth as the use of electronic information and telecommunication technologies that support that long distance healthcare, patient, professional health related education, public health, and health administration. So it looks like it's three buckets. I mean, they all kind of intertwine, but the important part here is that you'll hear HRSA, you'll hear the Health and Human Services talk about telehealth, and they're really talking about all of those buckets in there as well. And so it's also making sure that, for example, if you have remote healthcare services, those are telehealth type services that you would be providing. So telehealth, telemedicine today, as we know, there's been a real big shift to telemedicine. There's been like an increase of 67% during the pandemic, and allowing patients to be seen in home via telehealth has been a real trend. Particularly, we just did a presentation last week on mental health, and the percentage of folks that don't drop appointments or turn out to be no-shows are the ones they seem to be attending their telehealth because they don't have the problems with getting to the clinic. They don't have problems with getting sitting in that stigma you get from sitting in a waiting room. And so just kind of looking at the type of telehealth that's happening, where you can actually have patients attended to by a provider in another state, depending upon the compact rules between the different states. And then the audio only option remains a necessary option for those folks who do not have access or broadband. Some of the benefits to this is just having that access for rural or provider shortage areas, assuming they have the access through other, we'll talk about digital divide, but assisting in that. There's a lot of movement toward making sure mental health and primary care is integrated, so that when those individuals come in or they're on a call, they can bring in a behavioral health provider to help with that particular situation, and maybe that patient's more apt to go to that and get that care if they meet that person in a safe environment. There's also this continuity of care and follow-up, and being able to really follow up with the patients after they leave your office to see if, like they have some remote patient monitoring options that you can do, or blood pressure, other things like that. And then you're seeing that this whole stigma to mental health and other things of being in the office, they don't want to be seen in the waiting room, especially in small communities like a lot of tribes are. You see the person in there and you just wonder, why are they in there? Everybody talks, but making sure that we, that house reduces that stigma. And then privacy for patient. Now, this can go both ways. I mean, the privacy for patient means knowing that whoever's in the room with the patient when they're doing the televisit, that is a big piece of it. But it also, sometimes patients feel like they're more apt to provide more information if they are at home. Of course, there's challenges to everything, and these are just a handful of many different challenges that are probably out there, and you've all faced it, particularly as we had to rush into the PHE and public health emergency and actually put together some telehealth options. And I know that many of the tribal communities that we work with, they struggle with being in rural and isolated areas and having access to the cellular coverage or technology. Internet connectivity is scarce. And in according, for example, like Apache County has access to high speed internet. There's only 1% of the population has access to that. And then not having that reliability, it can make your telehealth appointments interrupted, unproductive, and then you have to, reconnect, and sometimes just having that ability to get in there. And then that limit to privacy was the flip side of the privacy on the prior slide. And then there's interconnectivity. This is where tribal communities have difficulty syncing their health data with electronic health record platforms. So that's being able to get the notes in, use the same tools, not have to go between multiple systems to be able to record the visit. And what is a digital divide? I keep referring to digital divide. This is, the gap between those who have access to technology and those who do not. It affects all generations, both rural and urban communities, as well as a variety of industries and sectors. So there's some groups of people affected by the digital divide. And the digital divide has kind of multiple things. One is like a digital exclusion. This means that if you're included under digital, it means that you have the individuals and communities, and including the most disadvantaged, have access to and use of information and communication technology. Because of the nature of technology, digital inclusion strategies must evolve as technology develops and changes. So if you're not staying up with the current technology, and then their tribal members might have less access to the technology to be able to participate through telehealth. It also is the issue of being able to afford the internet. There was a study by the Oklahoma State University that found that 20% of the respondents said they were likely to purchase internet if it were $50 or more, were $50 or more per month, while 74% indicated they would purchase it if it was $10 per month. It's pretty hard to get $10 per month, but there is options for the tribes to kind of consider what would be options for those who cannot afford it. Digital literacy, being digital literate, means that you've actually know how to use the system. You have the ability to, pull it up. I talk about my mom and making sure that she can access it, and how does, kind of showing her the right button to push, and all she needs is one button, but making sure that you're literate in the digital environment. And then just the limitations on when it comes to technology, and not everybody has the most current system. But some ideas on that we've seen some other tribes do is, provision of like loaner iPads and internet access that's provided through the tribe, self-guided kiosk where they can actually go up and put in information. It's in various public spaces that are private, but still in an area where like they go and they can enter information in. And there's people that help the patients and tribal members with the learning how to use what they need to do to be able to use the technology. So what do we see? We see quite a bit of different tribes working on getting a mobile workforce in place. That means getting a mobile clinic. It can be either a van, some type of thing where they can either support primary care, basic things, vaccinations. Some rural patients get a tablet, smartphone, et cetera. We've seen where behavioral health, substance abuse services, there's more mobile health being used to be able to kind of keep that in front of that patient to have applications or things on their phones or devices or computers that allow them to enter data as they go along, and you have practitioners that are reviewing it to see if there's a risk or anything. And the National Institute on Drug Abuse says some treatment medications and mobile applications are used to help the brain adapt gradually to the absence of the drug. And so it's one area to kind of consider from moving forward. Family practice modalities, that's really where we're using some of those remote patient monitoring tools to monitor the blood pressure, diabetes, other things like that. And I've even heard about medication, monitoring the medication box, because it basically alerts the provider if they've taken their blood, their medicine or not taken the medicine. And the school-based programs, many of the tribes we know have put in school-based programs, but you can actually put in what we call a hub and spoke model, where you have school-based telehealth programs, and the schools can be the spokes or the hub sites. And that allows them you have a clinical station at the school, because it's somewhere everybody goes, and it's easier to get in there than it is to maybe go to the clinic and things like that.
Okay.
So what is changing? Yeah, go for it, Kim.
There is lots of change coming our way. Some is already in place, and some we'll expect to see roll in as the PHE rolls out. So let's talk about what is currently in place. So in January of this year, several things were put into place, one of which was prolonged services, and CMS expanded how they were going to allow prolonged services within the various communities. So depending on the site, so for example, if your service is provided in a inpatient hospital or observation status, or nursing facility, or home or residence, there's been these codes created for you to use for when that length of service is extended past what would be normally included within your coding. Chronic pain therapy, there's 2 codes. Both are based on time, and really this represents a 30-minute service that is provided over the month. It includes coordinating care between like physical therapy and occupational therapy, working with those individuals on their treatment plans to get them to their desired outcomes and goals. One thing to note about this is it's recognized by CMS, but it's not likely recognized by other services. I don't think it's covered by Medicaid or some of our more popular commercial plans. exception to the direct supervision requirement under Incident 2. So there were some changes that were implemented for Incident 2. So currently, behavioral health services can be billed Incident 2, a physician or NPP's service, which means that the NPP must be in the office and immediately able to furnish a service in case something were to happen. It's been an exception right now under the waiver. And so they're allowing for more general supervision under that waiver. New behavioral health integration codes. So these services are really for your clinical psychologist or licensed clinical social worker. And it describes a service that is, again, reported on a calendar month, 20 minutes of service. And this has some particular documentation requirements. So it needs to be related to either an initial assessment or a follow-up of monitoring of that assessment. And it has to be related to behavioral or psychiatric health condition. Opioid treatment program changes. So on this slide, really just wanting to get across that there are some changes related with the fee schedule for things like methadone pricing and rate changes for individual opioid treatment programs. We'll talk a little bit about the DEA proposed changes in a couple of slides. And then lastly here, something that's new within the last couple of weeks, CMS has determined that they'll allow for a beneficiary consent for telehealth services to be provided annually. So you just need to get that once from the patient when they come to your office for that in-person visit. Also new for January of 2023 are the behavioral health services provided to a patient at home. New billing codes for home health agencies, and so with this, CMS created 3 different codes. Here, what's important to know is that January 2023, they were voluntary, but starting in July, they're going to be mandatory. So if your home health agency, you'll be reporting codes based on the way the service is delivered. So if you're using real-time two-way audio-visual communications, there's a specific code that you'll be required to report. Audio only has its own code. And then if it's a review of the stored and forward type information, there's a 3rd code for that. So hospital at home, this was extended through 2024. And really, this is a service that's designed to offer that hospital level type of care to individuals in their home through telemedicine. I think 3 key things here. One is that the hospital has to have established criteria for determining when a patient can have this service at home. That should be documented in a protocol policy type of document and maintained. And then it also needs to be documented in the patient's medical record that they qualified and how they qualified for that. And then you'll have to have a monitoring process in place that ensures that the standard of care is maintained and equal between inpatient and at home.
At 151 days after the PHE ends, there are some additional items I'll have. For example, in the original proposed guidance by CMS for the physician fee schedule, they had brought up this, or last year they actually brought up the concept of telemental health. And there's a whole page on HHS's website related to telemental health. And it's really related to providing mental health services under telehealth type services. And we have a couple slides, one slide on that. And then we're going that's going to postpone to 151 days, but doesn't mean you can't start putting some things together related to that. Then there's also extend the coverage of some of the temporary health codes, and those are, you'll see that those will be listed inside the listing of telehealth codes codes that are available to be billed using telehealth and the dates that that will occur. And none of those will apply to behavioral health that we can actually see, but most of it is in the medical and other areas. Frequency limitations. This is where they have situations where you can only have a certain number of services during the lifetime or during the actual year for a patient. And those were taken away during the PHE, but those will be coming back in. And those are particularly around inpatient visits and skilled nursing visits. And then if we get into, oh, go ahead.
Nope.
You're going to say something again?
Sorry.
Okay. Virtual check-ins and e-visits will be limited to just new patients. And then the remote physiological monitoring will only be new patients. And then the last one on here is virtual community service, has some requirement changes, which means it'll be limited to established patients only. So you can see kind of a movement after 151 days that they're moving away from that new patient visit and new setup of a patient for any type of service after that 151 days. And then through the end of 2023, in December, we actually have a big change, I think, is going to be this virtual direct supervision. Kim had talked a little bit about supervision and some of the changes for it, but originally, you had direct supervision and then you have what they call general supervision. And it just goes to the fact that during the telehealth period, we couldn't be in the same room or the same building as the other individuals. So this is going to be discontinued at the end of the calendar year. Of course, there's a lot of, people trying to swing this a different direction, but right now that's what they're looking at as the end of 2023. And then Kim, do you want to talk about the modifiers?
Yeah, I'll talk about the modifiers and the Category 3 changes. So as far as modifiers go, Medicare audio and video telehealth services will no longer require modifier 95 for telehealth services, and this will start January 1st of 2024. Instead, modifier 93 will be reported for audio-only services. Now, there's some specific requirements for RHCs and FQHCs and opioid treatment programs. You're able to select between modifier 93 and FQ. In some instances, you'll be required to report both. So it'll be important to start developing that list of modifiers and the appropriate place of service for those services going forward. Now, some of the flexibilities with what services can be reported as telehealth services under Medicare will change. Some have been made permanent. We talked about a few of those, while others, go away at the end of 2024 unless there is some additional congressional action taken. And I think the important thing here to note is that not every insurance company recognizes the end of PHE as a way of triggering a change in their billing. So CMS has been very clear about what they will continue to pay for and what they won't continue to pay for going forward. But it's always worthwhile to check with your other payers to see what their guidelines are. For example, Medicaid might be extending coverage in some areas, commercial plans as well. So very important to check. One great place to look at is the Center for Connected Health Policy. We have a slide in a couple minutes here that will point you in that direction, but they've done a really good job at outlining each state's requirements and kind of where they're at with their policy ruling.
Yeah, and I think the home address is going to be interesting because a lot of our providers have been doing telehealth from their home, and then during the PHE, it was allowed to, you didn't have to report your home address on the Medicare enrollment. So you could go ahead and just continue to put the clinic down. And unfortunately, at the end of 2023, that's supposed to be switching back to where you'd have to report your home address. Now, there's a lot of pushback on this. So keep an eye on the news and information about that because physicians don't tend to want to report their home on every claim form. So there'll definitely be, I think, some change to that. And then your opioid treatment programs, this is really, Kim's going to talk a little bit about DEA and some of the other changes that are occurring on that. But SAMHSA generally requires like a complete physical evaluation before a patient begins treatment in an opiate treatment program. However, during the PHE, you were allowed to do that through via audio, video, or audio only when you did your first in-person evaluation. But as at the end of 2023, that will actually change back to where it has to be in person. So, and there's also an add-on code that was added related to certain drugs when it comes to providing that, treatment. And then the payment parity in non-facility settings, there's going to, we had some benefit during the PHE where Medicare was paying the same payment for telehealth services as in a clinic, and it's no longer, it's been extended, but it's only for those that use non-facility service codes. So, Kim, did I get anything else you wanted on that one?
No, I think we got it.
Okay. Now, through the end of 2024, the flexibility of where the patient receives telehealth services and where the services originated changes. During the PHE, the definition of originating site was expanded to mean any site in the USA, including a person's home. Prior to the PHE, it only included the home in certain circumstances. Through the end of 2024, though, the telehealth service can be rendered regardless of the patient's or provider's geographic locations through December 31st, 2024. After that, it goes back to the way it was before. Now, again, there's a lot of legislation action going on about that to maybe change some of those for non-traditional originating sites like treatment of substance abuse, mental health, end-stage renal disease, and acute stroke. So keep an eye on that particular legislation as well. And then the audio-only telehealth, that is going to go away at the end of 2024 for all the non-behavioral mental health services. So just think about if it's an office visit, that would go away. So for audio only. And then we've had a great list of healthcare professionals who can furnish distance site telehealth services, like I know respiratory therapists were able to, but once that end of 2024 comes around, they will no longer be able to do that through a telehealth. And then the ability for FQHCs and RCs as telehealth providers expire at the end of 2024. And then there was a delay had been put in place related to the requirement for prior in-person visits provision of mental health services. So with telemental, there's a requirement for a mental health visit in person, but they delayed that till the end of 2024. And then I think overall, there's no date specified. CMS in all of their FAQs say check your state site, make sure you understand what the state licensures are. And what you can or cannot bill for another. So if a patient resides in California, the California laws basically state that they have to be, the provider has to be licensed in the state of California. So think about where the patient is, and that's where the licensure follows. So make sure that you keep an eye on the state licensure requirements.
I think one of the nice things is that CMS did permanently cover telemedicine services for mental health conditions, including audio-only treatment for mental health and substance use disorders. Now, this change that CMS implemented is really big. It's a chance for providers to continue working with patients and evaluating and treating them while the patient is in their home. Included in this coverage is two types of providers, the FQHC and RHC. And those providers traditionally haven't received reimbursement for telehealth services. So it's really nice to see CMS stepping up and allowing coverage for those services. So under this rule, Medicare will cover telehealth services delivered while the patient is at home if there's a couple conditions. One, the practitioner conducts an in-person exam within 6 months of initiating telehealth services. Two, the telehealth service is for the purpose of diagnosis, evaluation, and treatment of a mental health disorder. So it will be really important to ensure that your documentation includes those things as the primary diagnosis. And then after establishing your telehealth services, that you have to have an in-person visit every 12 months in order to continue using telehealth. So you'll notice one thing I wanted to point out is that that last bullet point there are some exceptions to the in-person requirement. Now they're very narrow and very limited, and CMS doesn't give us a list of what those exceptions are, but you might think about an exception that would require a person to come in for an inpatient or an in-person visit, and that might worsen their condition. So in that case, it might be appropriate to fall underneath an exception or waiver if you find yourself in that situation where you won't be able to meet that patient within 12 months after starting telehealth services. Just make sure it's included in your documentation. And I think we're all just really anxiously waiting to see what the DEA decides to do with their proposed rules. There's been two proposed rules from them, and really around prescribing controlled substances. And I've listed the rules on the right-hand side along with the proposed prescribing table that the DEA has put out. So in particular, this exception has been allowed under the waiver, and it's going to expire May 11th, unless there's something that has been codified into the rule before then. And so what the rules are trying to do is create a narrow definition under an existing exemption called other circumstances. And what the rule would do is allow for a 30-day supply of a non-narcotic medication. Beyond that, they're going to require that in-person visit in order to continue having that medication prescribed. And then that second rule there is kind of a carve out. It's specific to buprenorphine. Similar requirements here around having that in-person visit within either 30 days for a new patient or 180 days if they're an established patient. So not surprising, the DEA received over 35,000 comments related to these proposed rules. Their comment period closed, and they have 41 days or so to provide a response back to those comments. Really, the concerns expressed were around coordinating care and how that might impact the patient. Obviously, short notice with the DEA proposed rules, if they go into effect, it'll be a challenge to get patients to come in for their inpatient or in-person visit. And so not only do those rules impact opioid treatment with prescribing of buprenorphine, it'll also impact your patients that have medication-assisted treatment. You know, that's for other substance use disorders, serious mental illnesses, and co-occurring disorders. The requirement here for that in-person visit really depends on when the prescription was initiated. So if they were prescribed the medication before May 11th, there's a 180-day time frame in order to conduct that in-person visit. Now, after May 11th, there is a 30-day, and that kind of goes back to the exceptions that we saw on the previous slide. So there's a few different ways we're seeing people work to try and meet this requirement of an in-person visit. You'll see that requirement is pretty consistent among telemedicine services going forward. They do want that person to come in for a face-to-face visit. So there's a few different ways, strategies you can try out. One is getting a qualified telemedicine referral. And so this is where your patient is having that face-to-face interaction with a community provider or someone closer to that individual's home. And then at that point, the referral is coming over to you as a telemedicine provider. Another, which is kind of interesting, is a hybrid model. And so again, that face-to-face encounter is happening with a local provider, and the telemedicine provider is brought into the visit via teleconference. And at that point, there's this three-way discussion and referral made. A very interesting way of meeting the requirements. So either way, should these rules go into effect or not, it's going to be really important to ensure your documentation is supporting of these services. So really, I think one of the things they mentioned in the rule is that prescriptions will need to be tracked. So anytime a prescription is given for any type of medication through telemedicine service, you'll need to have a list. So thinking about how you'll have that list available should there be a request for it. Okay, let's jump into another polling question. So has your organization identified or assessed the risks of telehealth programs? Yes, no, planning on it, not sure, unsure.
I think when we talk to various clients, Kim, I think it's a variety of how they've determined their risk related to telehealth. It's like, okay, we have a problem, we've been monitoring it, but we don't have the right controls in our system to actually, kind of thinking about, okay, this is on our audit plan to actually audit during the year. So,
yeah. Okay, unsure or not assessed. Interesting. Okay. Well, hopefully we'll have some ideas for how to assess your program here.
Yep. So let's jump into the risk areas and talk about some of the risk areas that would be good for your organization to look at and determine if it's something you need to dig into. So we have seen a various amount of regulatory agencies that are, including the Office of Inspector General, that are keeping their eye on telehealth services. If you just go into what they call their active work plan on the OIG website and search for telehealth, you can find like 6 items. And one of the items just got completed on there, which is the top of the list in very small print, which is the OIG toolkit on analyzing telehealth claims. I think I alluded to it before, but that is now available. It's not extraordinarily helpful, but it can be combined with other types of reports and trying to figure out a way to start doing some data monitoring of what's happening with telehealth. It's also interesting, there was a report published in December 2022 on the government's perspective of telehealth use and program integrity. And they took a sample and looked at each of their Office Inspector Generals, so Medicare, TRICARE, et cetera, and IHS, and they collected data on the nature and use of telehealth in the periods of March of 2019, February 22, and then the first year of the pandemic. And they found some real, interesting things. Some of them are pretty straightforward about the increase in telehealth, but also that they found some system risk areas where they might indicate fraud, waste, or abuse, such as high volume billing, duplicate claims, and inappropriate charges for the most expensive level of telehealth services. And then just really a lack of data to assess quality of care and conduct any comprehensive oversight. A subgroup, which is another entity to keep an eye on, I didn't really know about them until about a year and a half ago, and it's called the Pandemic Response Accountabilities Committee. It's called PRAC. And they have a healthcare subgroup, and they also are monitoring this information as well and looking at what the government has put together. In addition to that, there was this, as I mentioned, this one report that was done, and they identified in this report some 7 measures that they felt were important to look at. So they looked at these 7 measures, they did some data mining, and based on that, they pulled a sample and they tested those areas. And I think as a data kind of geek myself, I enjoy seeing things like this where I can say, okay, let's start monitoring these particular areas, looking at the data, seeing what was billed as telehealth service and was it billed at the most expensive level to other things. And they've recommended to Medicare and Medicaid that they strengthen and monitor this type of data in their own system. as well as improve. They had some issues with incident 2 and understanding when it was done under incident 2, which is that, supervision of another provider. And then those folks that showed up, there was out of the people that they looked at, they had 1,714 providers they consider to be a high risk on how they're doing their billing. So, dig into this information. Nothing's better than getting some data and trying to pull it out and see if it really does show some trends for you. So our next polling question is, what does your organization consider the greatest risk? I'm not sure, you haven't done an assessment, but what do you think is the greatest risk when it comes to telehealth? Is it clinical documentation, privacy, security, coding and billing, scope of practice? And scope of practice means that the wrong people are, the people that are doing the work are doing it within their scope for the state, and unsure what the risk is. And I think it's, we do a variety of audits of telehealth coding and billing and documentation. And it's interesting when you start to dig in with a client and talk to them about their data, talk to them about how they know it was a telehealth service, is there an indicator in their system and things like that. And so just curious if everybody has any particular areas where I think there's a greatest risk. Okay.
Yeah, I'd love to know, since we have such a variety of people on the call, like what other areas do they consider risk? If you're willing to type it into the chat, I'd love to know.
Yep. Yeah, okay. Looks like we have a good number. So looks like the privacy security is up there, and there's a lot of unsure. So in the Q&A box, type away what you think are some of the risks that we didn't identify in that, and maybe we'll be talking about those already. So just wanted to, it's always interesting to see. So what are some of the risk areas? Well, the first area is just, we kind of touched on it a few times already, is just the service provided via telehealth does not meet quality and service expectations or requirements for supervision. And there's a documentation there to support both of those. I mean, if you go in and look at some of the, the documentation, was the service, did it actually provide the care? Did it do what it needed to do with that patient? For example, on remote patient monitoring, one of the things with RPM system is documenting a care plan after you reviewed it. If is there a change or no change to it, and really making sure that you're reviewing it, not relying on your RPM company to do all the work for you in order to get the billing for that. And then this whole concept of having an establishment of a practitioner-patient relationship, and there is this can be an issue related to whether or not how it affects your coverage. So there was a takedown. That's the government and the FBI and OIG and et cetera have identified some type of risk. And so they go out and they identify providers who hit a certain outlier or something like that. And they call them takedown cases. And according to the Department of Justice, this one takedown case they said that when the provider was actually filling out scripts for certain types of like certain types of DME and things like that, they didn't have a meaningful interaction documented between the provider and patient in order to order those particular types of products or services. And so having that meaningful interaction, that relationship is really important to your telehealth service. And one of the things that we, like Kim referred to, is this great site, and not trying to sell it, but anytime we have a question about a state guideline, we come to this web, and it has all of the different requirements that are allowed. I was just looking at the allowable for the state of Kentucky, and I don't know, it was a client that was asking some questions, and I could actually jump in there and see what was allowed, not allowed from a modality perspective. Kim, do you want to?
Yeah. Let's talk about a few more risk areas. It was really tough to see, but on that OIG data brief that Lori was sharing, they recognized that training was something that could present a risk area. And I think it's really important as we start to roll back on the PHE, and there's changes that are occurring, both immediate changes, and then over the next year, it's going to be super, super important to provide training to the workforce. And because there's so many different rules between, Medicare, Medicaid, and then even among the commercial plans, there's different rules. A single source of truth, like one access point for the staff, will be super helpful going forward. When you provide training, be sure to keep a list of, what was provided and when, and what the topics were. If you have to go back, say, and re-audit services for this period of time, what's applicable here and now won't necessarily be what's applicable a year from now. Monitoring is really going to be important, not just for the pieces of telehealth services, so documentation and that type of thing, but also monitoring around regulations. There are a few things that are kind of up in the air, DEA rules being one of them. So having a designated individual that's responsible for ensuring that the most relevant and recent information is available for use will be really important. Privacy and security, with the wind down of the PHE, there is a 90-day transition period for providers to come into compliance with the HIPAA rules. So review how your organization is communicating with patients to determine if there's any HIPAA risks. So I think it was like 30% of folks here thought this was a risk area. So definitely take a look at your organization. Make sure you're using encrypted email and that type of thing. So I'm going to go through this pretty quick, but I wanted to provide an example of how other groups are tracking key dates and changes. You'll find the link in your slide deck here. There's not only this brief here, but there's a bunch of them on the website that would be very helpful. Some additional items to consider. We've already talked about modifiers in place of service, and then not a covered service. So those are things like billing for phone calls. That's not really a telehealth service, but in our reviews, it comes up quite a bit. So just take a look at what services you're providing and make sure that they are actually telehealth services. Setting up charge capture and charge edits can be really helpful. Flag claims for review prior to billing them out. Utilize the information that you're finding through data mining in order to evaluate and update your charge capture edits. Documentation will be super important going forward, especially when CMS is going to require some specific things as to be done in order to allow for a service to be paid. Now, telehealth services will be allowed for the diagnosis, evaluation, and treatment of a mental health disorder. So those things need to be captured in your record. CMS stated that they are going to look at this. They are going to look to see what diagnosis is being reported for the service, and they're going to do some data mining. So it's good to get ahead of that and start running those reports for your own use. Consent is also important. The website that we were mentioning for the CHP, they outline which states have consent requirements and which don't. So if you're practicing across different states, be sure to look to see what the consent rules are for that state. There are differences. And then just documenting the service. Start and stop time has been one element where we really think it's best practice to document the start and stop time of the encounter. These are time-driven codes, so it's really important to make sure that your documentation includes that. Lori, anything else on risk areas before we wrap up?
No, I think there's just a lot of things around virtual check-ins that are pretty important because of timings and dates, and having controls in place that tell you that maybe you don't have enough time documented for those virtual check-ins, and kind of controls that are in place. And I agree with Kim, just knowing, that the documentation has what it needs and the template is set up properly Sometimes templates are used that are in a regular office visit, but you really should have a template for the actual telehealth visit that's different, and it captures the right information. And be very careful of copying and pasting time statements.
Yeah.
We just had an audit we did where the time statements were exactly the same. I could basically put them up against each other, and they would look exactly the same for 25 of the 30 claims that we reviewed for that particular provider. So really look at the information across the actual patients as well. And then just from a summary perspective, we appreciate everybody for attending, but it's a continually evolving area. And I think it's important to set up how you're going to look into this and do some audit and monitoring. And there's going to be a lot of things to pay attention to with the PHE ending. We want to make sure we look at our workflow. We want to untangle it, retangle it, whatever the process is, to make sure that the billing process captures things for us and we have the right things monitoring it from a work queue or report or whatever you have to do. And just start thinking about data mining. It's part of an effective compliance program, but just thinking about having some data mining if you have a system that allows you to do that. And with that, we're going to hand this back over to Amy to close out our webcast. Amy?
All right. Thank you, Lori and Kim, for a great presentation today. And then to our attendees, feel free to reach out to our presenters if you have additional questions. Their contact information is in your console, as well as a deck, which you can download now from the handouts window. Also, let us know if you'd like to set up a separate call to discuss this more in depth by dropping a note in the Q&A window. And then, as usual, we have a variety of resources on our website that you may want to check out, some of which are already linked in your console. The next tribal webcast will be May 11th and will be on the Inflation Reduction Act. There is an image in the upper right-hand corner of your console that will link you to a registration page for that webcast. And then if you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks if you have difficulty downloading it now. And then finally, here's a link to an online survey for today's presentation. And thank you for joining us. Take care, everyone. Thank you, Kim. Thank you, Lori.
Thank you.
Thank you.
Bye.